morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe. My name is Mitali Mistry, Senior Policy and Project Coordinator here at the IFA. And today I'm very excited to be introducing you all to Mr. Isaac Longobardi on the topic of the Moving Forward Coalition promoting action on nursing home quality improvement. Isaac Longobardi is a recent graduate of Harvard College. He currently serves as Director of the Moving Forward Nursing Home Quality Coalition. Previously, he worked as program coordinator for the Hebrew Senior Life Volunteer Youth and Community Engagement Generational Living at Center Communities of Brookline, one of Hebrew Senior Life's independent living communities. So thank you so much for joining us today, Isaac.
Thank you for having me. Really good to be here.
Absolutely. So as Luana mentioned in the chat, feel free to introduce yourselves and where you're tuning in from. We'd love to hear that. So just to start off our conversation today, I was wondering if you could tell us how you got into this work that you do now and what inspires and motivates you to improve the quality of nursing homes.
Absolutely. I was thinking a little bit about this question beforehand. I've been working in long-term care and elder services for a while now, and it's really my passion and purpose in life, as I imagine it is for a lot of the folks on this call. I got involved in elder services really as a young person because being surrounded by older people made me feel grounded in my community. It made me feel connected. Um, and I think as I benefited from those connections, I started to have questions about why sometimes those connections didn't go the other way as much, and why a lot of older adults in our community felt ostracized, underserved. I began to field and get involved and really start to dig into those questions and problems. And in the US, where I'm based, I really gained an interest in nursing homes, and the shortcomings of nursing homes, as well as, potentially some of the opportunities. And I know we're going to talk about that today. I'll say, the thing that keeps me committed and passionate and purposeful about this work is, in addition to the great community of the Moving Forward Coalition, which we'll talk about, and all the folks that inspire me in that community, it's continuing to stay connected to the experience of aging and long-term care in the U.S. As recently as yesterday, I was finding myself immersed in these issues in my own life. I'll share a little vignette, which I think sets the stage well for talking about nursing home quality issues. I know we're going to talk a little bit about nursing homes, but for folks who aren't U.S. based, right, nursing homes in the U.S. take care of really two sets of patient populations, roughly, at least from a payer standpoint. They do, right? You have the short-term stay folks who are coming out of hospitals, getting post-acute rehab, and you have the long-term stay folks who are, needing support for their whole life from that point on, and really in which the nursing home is invested in their quality of life and long-term care. My girlfriend's grandfather has been dealing with chronic pain for a while now. He went to a hospital. The hospital saw nothing really wrong with him, and the best thing they could think to do was send him off to a nursing home. And of course, if the hospital doesn't have much they're going to do for him, who knows what the nursing home is really going to do for him? But that's where they sent him, and the nursing home really just did a very, very poor job of managing his medications, and his pain got worse, and it started to, interact with delirium and confusion that I think a lot of us in elder care are quite familiar with, right? That experience got worse and worse and worse, and now he's back in the hospital. And as he's back in the hospital again doesn't really see any particular problems, trying to figure out the delirium, trying to figure out how to stabilize that. And they're already thinking about sending him back to a nursing home. So my girlfriend's mother reached out to me and said, "Can you help me look at this list of 16 nursing homes they've sent me? I'd like to pick a better one than the one he's been in." I live in New York City, so there are a lot of nursing homes here. It's in theory a lot to choose from. And so I started looking at the list, and we can talk more about this, but in the US we have a lot of quality data, so you can go and look at all the quality measures of the nursing homes. And I realized that the one he was in had basically the best quality measures of the whole bunch. And so, that put me and more her, my mother, in a really difficult position. And so I think understanding that in real time, is just another case where it's sort of redoubling the questions we have to ask in the coalition about, from the questions of consumer choice and, how do consumers make choice about the nursing home care they receive, to the question of quality. What are we measuring? How do we improve quality? What does quality really mean for consumers? To the question of medication management and thinking about sort of the cognitive experience of living in a long-term care community, deals with the cognitive needs of its patients. So just to say that, alongside my work, I'm continuously inspired by the experience of the people around me and their lives in nursing homes. So back to you, Mitali.
Yeah, no, thank you so much for sharing that. Just in the beginning, you were talking about, having that connection while just kind of, with the population itself, and to the way that you've kind of come about this work is really nice to hear. And then, the real life experience of navigating the system itself, and, you're seeing this data, you're like, wait a minute, this shouldn't equal to this, right? What else is going on, right? So it's fantastic that you're in this work itself and trying to help improve it. So thank you for sharing all of that. So as you are the director of the Moving Forward Coalition, I was wondering if you could talk us through what the coalition is and what its goals are right now.
Absolutely. So the Moving Forward Nursing Home Quality Coalition was launched in July of 2022. And its mandate is funded by the John A. Hartford Foundation. I see Jane Carmody on the screen here. She's our senior program officer at the foundation. Um, and hi, Jane. And uh, it really took its mandate from a report published by the National Academies of Sciences, Engineering, and Medicine, also in 2022, called the National Imperative to Improve Nursing Home Quality. And that report looked at all, it was 600 pages or thereabouts, a really big report, looking at all the systemic issues in nursing home care in the US. I think arguably it was a response to the crisis and tragedy of the COVID-19 pandemic in US long-term care facilities and nursing homes in particular. And but really looked different. It saw the problems that COVID brought to bear on nursing homes and said, what's underneath the hood here? Sure, there's a virus, but there are also questions around, most notably infection control, but you can also think about the physical environment, care that's being provided, the way we finance this care, the way we oversee care, that are sort of nursing homes sort of vulnerable and at risk for these really horrible effects of the COVID-19 pandemic. We so that report comes out, and in that report there are about 35 recommendations across a number of domains, some of which I just mentioned. And the John A. Hartford Foundation keenly wanted to make sure that that report was not just a book sitting on a shelf. So they funded the mission via LEAD, which is a association of nonprofit elder service providers, to take that report, convene a bunch of stakeholders across the field, and we can talk a little bit more about that later, but we're talking about residents and their advocates, direct care workers and their advocates, various types of clinicians, various types of providers of nursing home care, policymakers when they were willing to join us, truly everyone and anyone who was willing to come around the table, get together, prioritize recommendations from that report, and start action planning is what we called it. So taking the recommendations and say, how can we do this work together? As we were doing that, and I'll really speak, our chair, Alice Bonner, who's primarily appointed at the Institute for Healthcare Improvement, really had a philosophy of like, what can we do now together? Reports are great, but we didn't want to put out more recommendations. We didn't want to pass the buck. We wanted to get these folks together in the room and say, what can we as a group do? So we really emphasized practical, immediate action in our work around these recommendations. And then starting about a year and a half ago, we really hit the ground running, trying to do as much of that as we could. And so now we're really in a phase of our work where we're focused on collaborative quality improvement initiatives, and advocacy and education. So happy to talk more about that, but that's really what we're doing. Just to share a little bit more, we're getting up towards about a network of 1,800 people who are engaged in some way in the work, over 50 organizations who are sort of actively supporting or partnering with us. And we continue to just speak to everyone and anyone who's willing to listen. Uh, Not because we think everybody will agree, and we can talk a little bit about that coalition building and what gets across to different groups, but because we think elevating the cause of improving quality of care for residents and improving quality of work for staff is vital for everyone in our country to really be a part of. So that's what we do.
That's amazing to hear. Yeah, like often, incredible organizations such as yourself, you put out these, great big reports that have all the data, you have all the recommendations, but it's fabulous to hear that you guys are actually putting the action forward behind all of these things and really trying to make a difference with nursing homes in general. So that's amazing. You've already kind of mentioned this, but if you wanted to touch on it a little bit more, globally and regionally, even within countries themselves, the definitions of, nursing homes, long-term care can vary quite a bit. So to help us better understand the context of the coalition's work, which is based in the United States, as you mentioned, could you explain to us what the term nursing home would entail in comparison to, for example, long-term care and other kind of sorts of related terms?
Absolutely. So I studied anthropology in school, so I think about this question in in a lot of different ways and think sort of how we define our institutions and organizations is really interesting. I mean, most simply, I think, right, if you have a long-term care continuum in the US, right, nursing homes are sort of the far end of that continuum. They're providing them the most acute, serious level of long-term care primarily for older adults, but not entirely for older adults. So, interestingly, one of the things the NASM report highlights is that the fastest growing demographic group in nursing homes in the US is folks under 65. So, who nursing homes serve is actually really shifting in the US. And that's, I think, part of the challenge that, folks on the coalition really have to grapple with is that as they think about how can nursing homes do their work better. But nursing homes are sort of that far end of the long-term care continuum. As I said before, they sort of have two service lines, if you will. One is that short-term post-acute care, which is typically funded by Medicare or private insurance after you've been in the hospital. And the other is that long-term stay that's really moving into a nursing home. It becomes your home, and that's typically in the US funded by Medicaid. Medicaid is a sort of, for folks who are outside of the US, Medicare is a total federal payer, though we now have some private insurance components to that. And Medicaid is a state payer that's matched by federal dollars. So you'll notice that the long-term stay financing in nursing homes is a little bit more variable than the short-term stay financing because you have 50 different programs effectively of long-term care financing for nursing homes. So that's sort of one component. The other thing I'll say is nursing homes have changed a lot over time. If you sort of look at the history of a nursing home, the modern nursing home doesn't really appear until probably the 1950s or so, before you have something probably that looks like a poor or almshouse, right? That's providing care to older folks who are poorer and don't have families who are able to care for them. In the 50s, we start seeing investments through the Hill-Burton Act in hospitals and other healthcare facilities. And that's when nursing homes start to really formalize as sort of health organizations and start to expand. Um, in the 60s, you see more regulation, you see Medicare and Medicaid coming into being, and that starts to when you really see the construction of the modern nursing home. Now, and this is where it really gets interesting, and this is some of the moving forward coalition's work, is what a nursing home looks like is kind of changing again. People don't really want to live in the 1950s version of a nursing home. And so I think, I think and hope that over the next 5, 10, 20, 30 years, nursing home's not going to mean the same thing to us anymore. We may not even call it a nursing home anymore. And I'm happy to talk more about some of those sort of historical trends and shifts in what a nursing home is in respect to the long-term care continuum.
Yeah, no, that's fantastic. It's good to hear the history of it all. It's particular to the States, but it's really good to know, okay, like this is where we're coming from, and it's showing that it's evolving right now. So it's always good to keep in mind, okay, so this is what it was, this is what it presently is, and this is what it might change into. So it does kind of inform the work that kind of goes into making changes for the right populations. Amazing. So as you mentioned, we just briefly talked about that this is a coalition itself. So coalition building is an interesting process, bringing together different stakeholders and sectors to support this collective goal is an amazing approach to really achieve a large goal, such as improving nursing home quality. Would it be possible to hear your thoughts on the process itself? For example, what it needs to be successful, how it can positively impact the goals of the coalition itself, and some of the challenges along the way.
Absolutely. So this is really, I mean, it's funny, right? Because we're talking about some of the context of nursing home, and I love the issues and whatnot. But the bread and butter of my job is really putting together this coalition and making sure it stays on the tracks. And what I'll say about that is I've learned a lot. So I've been with the coalition since its inception in 2022, and before that, I was working in a nursing home and really working on the ground in long-term care. And so when I came into the coalition and sort of I had a lot of awakenings about sort of, what is the sort of political landscape and policy climate of the care work that I had been a part of on the ground to that point. And one thing I noticed right off the bat, and I don't think this is to folks in the US who work in nursing homes, this is not a shocker and nothing new, but to them, but we are in a intensely divided field in nursing home quality. It's interesting. I've friends and colleagues who work in other social and health services spaces, and I'm often sort of surprised by the degree to which in the nursing home space we deal with a lot of folks on the ground in nursing homes at odds about how to move forward in terms of quality in a way that I think a lot of sort of potentially analogous sectors do not. And that divide is really typically between, it's probably tripartite if you really break it up, right? You have sort of the nursing home providers are typically in one camp in terms of sort of uh, policy issues. You have resident advocates and in a second camp. And then you have policymakers really in the third, and in the classic sort of formulation of any good market, you also probably have labor as a sort of fourth camp. And if you're a Marxist, you can go into that. I'm not really going to do that because it's a different kind of podcast or conversation. But you have those four buckets, and when you really have a conversation with any one of them, the big picture goals are all the same. All of these folks are really invested in making sure nursing homes provide really high quality care to residents and provide a great work experience for staff because that's the bread and butter of this stuff. They really are all invested in that quality, but how they want to get there is really different in terms of the strategies and approaches. And there are a number of issues that are sort of, I would say, mid-level issues in terms of the degree of macro to micro that have created a lot of tension in the space and have really bubbled up in the last 5, 10 years probably, and are one of which sort of staffing mandates, which we can talk about a little bit more, has created a particular amount of tension. So, that was sort of the landscape I came into, something I found it very, very divided. But credit to the Hartford Foundation, credit to Alice Bonner, our chair, and credit to the people who really made up, the steering committee of the coalition, and that's many committees. They wanted to create a space where we could move past those divisions and find some consensus beyond that. And I think, if the primary mandate of the coalition was to work with the NASEM report and move forward some of those recommendations, I think the secondary sort of less explicit mandate of the coalition was to bring these folks together and start having some real conversations and see if we can move past our differences. Um, and so, we've really had to think about maintaining true diversity in all our work groups and committees, making sure that each of those perspectives and many, many more are at the table together. B, making sure that the conversations are genuine, that we're not getting stuck on old debates and really trying to find new areas of consensus that have, possibility for progress and action. And C, we've really had to think creatively about that. And so I'll give you an example. So we had a workforce committee. Right now, if you're following U.S. nursing home policy, basically the biggest topic at play is a staffing mandate that was made into a final rule, sort of finalized in federal regulation in the spring, I believe that was finalized. And that mandate basically set a minimum staffing level for nursing care in all nursing homes. And consumer advocates, well, truthfully, nobody was really happy with the rule because the consumer advocates wanted to see a much higher level of staffing. And the providers said, there aren't enough staff out there. We really have a workforce problem. It's tied back to
Mhm.
immigration. You know, we're not going to be able to make this come to be. And I think from my personal perspective, I think there are truths to both sides. And I think as a coalition, we realized very quickly that we weren't going to solve that debate. It was much too entrenched already. Folks were too sort of set on their minds, but we knew that staffing was like the biggest issue in nursing home quality, right? If you look at most studies, you find that like staffing levels are one of the biggest correlates with quality in nursing homes. So, we wanted to push folks to think about what else can we do to improve staffing alongside this. And so we've really focused over time on sort of recruitment and retention, primarily through career pathways in nursing homes, and primarily even more focused through registered apprenticeships, which are a federal program that, at least under the Biden administration, was getting a lot of funding to support career advancement across industries. And so we really wanted to see nursing homes access that more and get more certified nursing assistants, the lowest level, most direct care work on the nursing home staffing chain, involved in that. And so we've really created a great focus on that career pathway work and sort of bringing national standards and national stakeholders together around it, because we believe, wherever you end up on the staffing mandate debate, wherever federal policy ends up going there, having those pathways and having federal funding for those pathways is really vital. So, that's a little vignette of how we've tried to keep all these boats moving together, even as we have some of those long-term contentions in the field.
Yeah, that's fantastic to hear and really interesting that yeah, the staff I think point is really integral even here in Canada. I think it's like one of the more like important factors to look at. So it's interesting to hear kind of how that's been affecting everything. And it's great to hear that the coalition itself is very like, okay, we have this like main point of interest that we're all kind of come together and focus on to really push forward with action. So that's lovely to hear. And so you've mentioned this a few times, but I would love to hear a little bit more. Can you speak on the NASM report, or the National Academies of Science, Engineering, and Medicine report? So the goals that came out of this report were really foundational to the Moving Forward Coalition's discussions, and be great to hear how like this report has really informed the work that's being done by the coalition.
Absolutely. So try to put this in context of a few things now. The NASM report is our sort of like Magna Carta or Constitution or what will you, right? That's the document. I mean, like I have
Mhm.
it right here. That's like
Oh, perfect.
this is my everything. So and for our coalition, it's everything. And that's, from a coalition building perspective, that's been really interesting. I'll talk about the content in a second, because on the one hand, I think having that guiding document has been really important for us, because when we've had the uh, folks pulling apart, that report, that sort of central document keeps us together. We can all come together around this report. Now, I will say, not every stakeholder in the coalition agrees with every recommendation of that report. In fact, probably everyone has at least one recommendation that they take at least partial issue to. So, a big part of what we did early on was prioritizing those recommendations and picking a set of basically 9 that we were going to focus on even more specifically, and had the sort of collective support of the group. So, that was a key sort of aspect of the coalition building, and the report is very central to that. In terms of what's in the report, as I said, it really is a deep dive. It's a big report into the sort of details of nursing home quality fall apart in this country, and what are the systemic factors, from financing to care delivery to oversight, that makes nursing home quality fall apart. What I appreciate about the report in particular is that it has a deep focus on the folks who work in nursing homes and the folks who live in nursing homes, and what the sort of it means to have a good work environment, an empowering work environment, and also what it means to provide really person-centered care for residents. And we can talk about that concept. It's become really important to what the Moving Forward Coalition is. What else do I want to say about the NASM report? I will also say about the NASEM report that it also exists in a lineage. So the National Academies of Sciences and Engineering and Medicine has evolved over time, but in the 80s, its sort of predecessor organization published a report on nursing home quality as well. Equally big report, and that led to or was one of many things that led to some pretty substantial legislation in 1987, the Nursing Home Reform Act, on sort of improving the quality of nursing home care. And that really created the modern regulatory environment for nursing home care today, sort of put in place nursing home resident rights, hugely important. Um, it created the modern survey system for nursing homes and did another of other things to sort of clamp down on various forms of abuse and neglect that were going on in nursing homes back then, and arguably in some cases still unfortunately exist to this day. But so when this report came out, we were really excited, and I think folks across the field were really excited because it feels like this new um, uh, guide star for us. You know, if there
Yeah.
was that 1980s report, now we have a new report, we can sort of rally the troops. And I think we really have used this report to rally the troops around it. Uh, we learned a little bit ago that this report is, it's online, free if you want it. You can go just look up NASEM Nursing Home Report. You'll get it very easily. You can download all 600 pages. That download it's been downloaded over 12,000 times, which is
Wow.
the top 1% of any National Academies press publication really ever. So, to me and to the folks we work with, that's pretty shocking because nursing homes are a relatively neglected issue in the U.S. So the idea that this report of all the things that National Academies Press, publishes on was going to be top 1% really spoke to the fact that it was having some sway. And it's also been referenced in a lot of policy making at the federal and state levels over the last 2 years. So we really see this report as a sort of a flag to rally around. Not everybody's going to agree with everything in it, but hopefully there's something in there that whether you're a policymaker, an advocate, a leader in your state, you can say, I really believe in that, and I'm going to take that recommendation to my state house, to my representative, and make some change with it.
No, that's fantastic to hear. First, like how your coalition itself is kind of using it. But the fact that it has that many downloads is really impressive. And it's incredible to hear, people really want to make a difference and change. And so they're like, okay, if there's this great resource here, what can we do? How can we utilize this in our own work, or maybe, support the coalition itself and other kinds of organizations that are working towards making this change. So that's fantastic to hear. And of course, we can also post that resource a little later on if anyone wants to kind of take a look at the report. 600 pages, but the holidays are coming up, so it'll be a nice read for everyone to kind of go through. Yeah, absolutely. We'll post the link to the report in the chat as well. And I think in between, you did mention person-centered care. If you wanted to kind of speak on kind of how the coalition is working towards on that concept, or explain the concept and then also how it's working towards that concept as well.
Absolutely. So, empowering residents is really core to our work. It's something that we all believe in and we're all really dedicated to in our coalition work. And then, I mean, the beauty of this coalition too is that most of the folks who work here are also doing amazing quality improvement work outside the coalition as well. So we have just this beautiful network of people really dedicated to creating and improving what person-centered care is in U.S. nursing homes. There's a lot of lingo around person-centered care. Some people call it person-directed or resident-directed care. The idea being that, care should begin with what the nursing home resident themselves wants. And of course, that has many complicating factors, especially when we think about dementia and other cognitive conditions that are quite common in nursing homes. I think it's upwards of 50% of folks in nursing homes have some form of dementia. So expressing what matters most to folks is can be challenging in some contexts in nursing homes. But we as people who care about nursing homes and who care about nursing home residents, we have a dogged belief that no matter what, we can find a way to understand the needs and wants and desires, what we often call the goals, preferences, and priorities of nursing home residents. So we've really divided that into two buckets, and I think they say a lot. The first bucket is that sort of goals, preferences, and priorities of the individual. You know, nursing homes, and one, they plug into the long-term care system, but two, they plug into the health system, and they are medicalized settings. And so we typically have organized nursing home care planning around the sort of health and medical care needs of nursing home residents. But if you move into a nursing home, your life is much greater than just your medical and your clinical needs. And so one of the things that one of our committees has really worked on is how do you talk about and collect, nursing home residents' personal goals? How do you then bring that into the care plan and communicate that to nursing home team members so that they can then go and actualize those goals, preferences, and priorities in the experience of everyday living of nursing home residents? And then, perhaps most important of them all, and perhaps least done, how do you close the feedback loop, right? How do you check in with residents, make sure their goals are being met, make sure their goals haven't changed, and if they have, revise your approach. So that whole circle of work. And so what we've done and what one of our committees really focused on was sort of understanding what are the best practices out there for doing that in nursing homes, documenting that really clearly. And now we're going out and working with nursing homes to really implement and pilot that and improve that sort of goals, preferences, and priorities cycle. And we're doing that in partnership right now. The process of sort of developing those best practices and collating them was a committee-wide process, and we had, I see Mary Lou Chialfi's on this call, and she was on that committee and a key leader in that work. But we, did a lot of convening across the country to do that, and now we're really piloting that in with Kansas State University's Center on Aging in some Kansas nursing homes, and are really excited about the progress. The other side of that, which, I think a lot about anthropology and nursing homes as really communities as well, right? That's something I haven't talked about a ton yet, but nursing homes are social communities. You have multiple people living and working together over long periods of time. So in addition to the sort of personal, individualized goals, we also have to think about the community's goals, preferences, and priorities. And we believe strongly that nursing home residents should be leading that. They should be at the forefront of creating the communities they want to live in. So the other side of our work that's really organized around person-centered care is work around resident councils and improving how resident councils run. And what we, think about in resident councils is the idea that, oftentimes in most nursing homes do have a resident council. If, I believe it's in regulation. In fact, I know it's in federal regulation that if at least one nursing home resident in your nursing home wants a resident council, you must have that resident council. So in theory, they exist in all nursing homes. But what you find is that they're kind of siloed from the actual operations of nursing homes. They may not actually have the impact and receive the sort of responsiveness from the administration and leadership that they really deserve. And so they're not really shaping the environment in the way, in a lot of cases, they should. And so what we're really working on is helping create sort of best practices and sort of momentum around really engaging resident councils in quality improvement work and administrative decisions so that they have a real voice. And so right now that again comes out of the committee work, and right now we're focused on piloting that idea in Connecticut. Our goal is that every nursing home in Connecticut over the next 3 years will have a strong, effective resident council. And we're working with the long-term care ombudsman there, which is a federally funded state position in every state in the US to sort of get that idea out there. And we're doing a lot of trainings on the ground with the 200 nursing homes in Connecticut to kind of make that a reality. So that project we kind of have been doing the upstart work on it over the course of the fall, and we're having our kickoff call with the first set of nursing homes on January 7th. So really excited about that work as well.
That's fantastic to hear. And yeah, thank you so much for kind of going into that topic there with person-centered care. Just on the topic of that, we have Jane Teasdale, who's put in two comments in the chat. Jane, if you wanted to unmute yourself and speak on any of your comments right now. If not, then I might just read through two of her comments here. She mentions in her first comment, developing person-centered models and framework is quite complex. Oh, she's having technical issues. No worries. I don't mind reading through it. So, developing person-centered models and framework is quite complex. Focus on the person, their hobbies, interests, goals, and connection. Proper training and understanding of person-centered care training for management, nurses, social workers, personal support workers. So the whole realm, it's quite complex to kind of consider. So I know you touched on that, but I don't know if you had anything else to add to that as well.
Um, Yeah. So I mean, I think I'll bring in one other aspect of the work on that. And in terms of person-centered care models. So, one of the things I alluded to is that nursing home care may not look the same, hopefully won't look the same in 5, 10, 20, 30 years. And so we do a lot of work on what in the US are being called often sort of household models. And those have different variations, sort of most famous or prominent of them right now is the greenhouse model, but you see other versions like the Eden alternative and action packed and some different variants, and then also just sort of bespoke models being taken on by different nursing homes. And the idea is you take that sort of post Hill-Burton hospital-like nursing home and you say, this isn't right, and you break it up into really households or neighborhoods that are smaller collections of residents living in private rooms around a sort of a family style common room with an open kitchen, access to the outdoors, and then staffing patterns that really are much more horizontal. So you have, less hierarchy in staffing, more sort of holistic support from individual staff members who are consistently assigned, and then cultural changes in the organization that really emphasize the idea that this is a home for people. And so you create sort of if you take, person-centered care as it at its most simple form, it's just a philosophy of engaging with a person about their goals and preferences for living there. But if you go the extra mile and start to think about how do we change the whole organization to really create a person-centered environment, a home, because I'm going to be living here now for the rest of my life as a resident, then you start to create these really interesting things. And we're really in favor of that. There are challenges, certainly in the US and probably elsewhere, to getting that done. And the one that we really run into a lot is the financing challenge. And, we're really working on how can we incentivize the construction and renovation of nursing homes to look more like this. And part of the challenge is upfront capital, to be totally frank. To rebuild the building, you need money. And nursing homes are often cash strapped. And the other component of this is if you take every double room you have, and a lot of nursing home rooms in the US are doubles, and make them private rooms, that's half as many reimbursement dollars you're getting from the government, and that can also be a challenge. So we're trying to really think with state policymakers and other leaders about how do we make that model viable, and that's an uphill battle right now, but it's really one that's important to us. So some thoughts there.
Yeah, thank you so much for that. And thank you, Jane, for posing that comment there. I'm just going to jump back, I think, a little earlier in the chat. So feel free if anyone has questions, comments, please pose them in the chat. We're just going to go through some of them now. We have a question here from Shmuel, and he asks, how does the coalition try to improve the quality of nursing home for those coming from more lower socioeconomic backgrounds?
Absolutely. So, as I sort of mentioned, one of the biggest payers for nursing homes is Medicaid, which is our sort of our safety net health insurance provider in the U.S. Um, and so, one thing I will say is increasingly as wealthier individuals are able to pay for more care at home, what you're seeing is that nursing homes, in addition to providing sort of a more acute care for folks who can't live by themselves, are really becoming the de facto long-term care provider for folks with lower income or lower socioeconomic status in our country. So part of me really, really believes that anything we can do to improve nursing home quality is improving nursing home quality for lower income folks. This is really right now work that's about creating change. If you're improving nursing home quality, you're serving, excuse me, those folks who have less access to resources. So something to put out there, just to get started. What I'll also say, and what's really important to us, is making sure that the changes we are talking about are accessible. So I'll go back to that household model conversation, for example. You will notice that the majority of the household models in the US are serving typically wealthier individuals. And part of that reason for that is that financing problem, right? If you're taking private pay individuals, you can afford to do more expensive modifications than if you're running on Medicaid reimbursement. And so our real talking point is this is an equity issue now, because if all the wealthy people in nursing homes are living in these beautiful households and all the sort of non-wealthy folks are living in traditional nursing homes, that's a real disparity. So what we're really talking about here is making that accessible to lower income folks, which is why we're talking about adjusting the Medicaid rate and creating Medicaid incentives so that nursing homes that are relying on Medicaid for reimbursement dollars and are taking Medicaid patients primarily or residents can really make these changes. The other thing we've looked at a little bit is so most of the new U.S. Nursing home funding is flowing through Health and Human Services, so Medicare and Medicaid. However, there are some other programs in the U.S. that finance nursing homes in various ways. One of them is our Department for Housing and Urban Development, which mostly focuses on housing, provides some mortgage insurance to nursing homes considering construction and renovation. And what we've really encouraged them to do is to explore how we can make sure that their program is financing construction and renovation that A is going to really create new quality of the physical environments of nursing homes, and B is targeted towards nursing homes that are serving lower income populations. So that's a really important goal for us, and we're really keen on that. The other thing we really think about is, in all our pilot projects, when we're talking about, for example, improving goals, preferences, and priorities-based care, how do we make sure that that is accessible to some of the lower resourced nursing homes out there, right? I think, a lot of the best financed and resourced nursing homes have really started to modernize, much as we talked about with the household models. But we need to make sure that there are, person-centered care does not need to be that complicated. At the end of the day, as some of our best folks will tell us, it is really about having real conversations with people every day. It doesn't need to be a super expensive intervention, but we need to make that clear and bring that sort of, simple human framework out to folks, no matter what setting they're working on. So that's a really key thing we're talking about across multiple dimensions of our work.
Fantastic. Thank you so much for sharing that. And yeah, really, having those conversations and truly listening to what is needed and what they want and kind of feeling, okay, let's implement this. Let's start doing it. Let's putting the action towards it. Absolutely. We have a question here from Catherine Klein regarding the potential new administration coming in. Catherine, would you like to unmute yourself and ask your question?
Sure. Hi. I wondered how you're looking toward dealing with the new administration, where it's likely many of the ideas you've been supporting will not be continued with the next administration and indeed may be undercut. So how is your coalition trying to figure out what to do?
Really, really great question. And I wear two hats here. I wear my coalition director hat and I wear my personal hat. And I will say, sort of sidebarring as a person for a second, I am very worried about this. I'm very, very worried about this. I think as a coalition, we are, and again, I'll just say our chair Alice Bonner is there are no excuses. We have to act no matter what. There are 1.2 million people living in nursing homes. It doesn't matter who the administration is, we have to improve the quality of care for them as soon as possible. So that is really our value. So, we're going to keep doing what we do no matter what the administration is. And we're going to keep advocating and educating every policymaker we can talk to about the quality of care issues in nursing homes and what they can do to improve that quality of care. The strategy and tactics of that are going to change under a new administration, and everybody we work with recognizes that and is trying to figure out what that means. And some of it we don't know. I think it sounds like, Catherine, you're pretty in touch with a lot of these changes. And if you read, I think there's a sort of a spectrum of expectations with every new appointee about where they're going to go. There's sort of, it's kind of unclear what the policy direction of new folks will be. Though we know it will be different. We're actually thinking right now, I was emailing about this yesterday evening, sort of convening some conversations of our sort of leaders who are most sort of enmeshed in the federal policy work to start to sort of tease apart what those different strategy and tactics will be. There may be areas, as one of our folks said, that actually get more play. Now we don't know, and we need to start having those conversations. But I think the bottom line is we're not giving up. We're not closing shop. We're going to keep doing our advocacy education work on behalf of folks who live and work in nursing homes.
Perfect. Thank you so much for that. And thank you, Catherine, for that question. Um, we have a question here that's interesting from Peter Whitehouse. He's asking if you know Toon Totes. I don't know if I'm pronouncing that right. And his work in the Netherlands and his film Human Forever. He visits innovative care facilities around the world, including our intergenerational programs. And your thoughts on caregiver robots as well.
Okay, on and Tune, and I also don't know if I'm pronouncing his name perfectly. I've heard a lot about his work and need to watch his movie. And I think he's doing really amazing stuff. As you can probably see from the screen, I'm not terribly old myself. He's a younger person, and my a side project and focus of mine is to engage more young people in this work. I talk to a lot of folks who say, I don't think there are a lot of young people involved in aging. How do we change that? And I think the truth is there are actually increasingly a lot of young people involved. And part of the reason is we have an aging population around us. A lot of young people are growing up in multi-generational households, caring for older adults in their lives, and they see the seriousness of demographic changes around them. They see the seriousness of poor quality of care, and they want to make a difference. And I think Toon is an amazing, really inspiring example of that. And I think there are a lot of young folks in the U.S. certainly who are going to be inspired by his work and want to follow suit. In terms of robots, interesting question. I'm torn, and I'll say, I was reading around online as I often doing, and I don't remember who posted this, but I saw someone post an article about how human contact is becoming a luxury good. The idea that, perhaps before technology was the expensive thing that the wealthy and most privileged had access to, but actually increasingly technology is becoming cheap. Having, real person-to-person contact is what is becoming the expensive commodity. And, from an equity perspective, I really believe deeply that we want to make sure every person has access to real human-to-human care, that has access to those personal connections, because I think, as folks on this call certainly know, a big part of what is ailing our society, especially when it comes to long-term care, is loneliness. And that's true in home and community-based care. It's also true in nursing home settings, where many of the folks in nursing home settings are not receiving visitors. They have maybe very few friends, if any, in their nursing home communities. And I think making sure that we have that human-to-human contact is really to me a moral imperative. That said, I think I'm also a pragmatist, and I think technology can have a lot of positive impacts in terms of just improving quality and consistency, especially around some of the clinical aspects of what we do. And so I think it's about a balance, but I hope it doesn't displace that human connection that we should be striving towards.
Absolutely. I think, yeah, for a personal perspective, technology should only supplement kind of what we can provide as humans to one another. So that's, yeah, interesting take on that. And I need to look at that movie as well myself. Thank you for bringing that up, Peter. We have a question here from Nadine Chambers. If you're here, would you like to pose your question?
Hi, good day, everyone. I am coming to you from Jamaica. We are experiencing a significant return of Jamaicans who live overseas back here. But one of the challenges I'm foreseeing is that we don't have elder law in of care are yet to be refined, and a lot of persons who return home are expecting similar standards as they see in the United States, Canada, and England. Another challenge that some of them are having is it's not so convenient or easy for them to have their pensions accessed when they have them supposedly arranged to be transferred here. I've also heard regionally that there are some CARICOM countries, Caribbean community countries like Dominica, St. Lucia, some of those where their pensions from England are actually cut by as much as 50% if they decide to return to their home of origin. I think it's going to be important, especially faced by persons who went over to rebuild England after the war. They're now being told that they're not citizens, they have no right to be there. They're also facing hostilities in Canada. A lot of persons would have wanted to have their other families migrate with them for the intergenerational family support. That is also becoming a problem. And I think if we don't address this sooner rather than later, especially as there is seeming to be a likelihood of a global economic meltdown, the disparities in care are going to become more pronounced. We already have a problem with, as much as here in Jamaica, as much as 60% of our population is considered to have non-communicable diseases, NCDs, heart disease, dementia, Alzheimer's, all of those things. So we don't really have internationally recognized standards of care. And it's going to have, of course, a spillover effect in terms of how our young people are cared for. Already we're seeing a decline in our birth rate, and our young people traditionally migrate intending to have better lives. So I think it's going to be important that we have some kind of harmonization of elder care law, financing of homes, standards of care in homes, put on the global development agenda. Yes, sooner rather than later. We seem to be having some kind of regression going on, but in the meantime, we need to be cared for. Our families need to be strengthened. And I think it's starting to overwhelm a lot of us because even here, our young people do not come back home, they stay. So we have a lot of elder people in these huge homes. Jamaicans tend to build big homes, 3, 4, 5 bedroom homes, and they're alone. And nobody knows what's happening with them. We have no proper tracking device. We have no proper care environment. The government budget has been pressured with having to pay back loans. And overall, I think, especially during COVID, there was a massive slowdown. Elderly persons were ordered to stay home with no follow-up care. So now that those restrictions have been lifted, a lot of those consequences are coming to light, but we're still not prepared or ready to deal with it. And in the meantime, yes, life goes on, but the consequence answers yesterday, and it really needs, I think, to be on the global agenda so that it will find its way by way of international agreements onto national agendas.
Thank you so much, Nadine.
I-
Isaac?
Thank you, Nadine. I think that's such an important set of comments and thoughts, and I'll add on to what you're saying. And one thing sort of from this US context, we talk a lot in the US about a sort of quote unquote care force shortage, right? We don't have enough folks to care for the aging population that we have. And of course, the solution that typically comes to folks' mind, and for good reason, is immigration, right? We need to bring in more folks who want to move to the US from around the world, help them become, care partners in our workforce. And, the best and brightest of us think we also need to support them better and, provide more access to resources and better compensation and all those things. But what I will say is, as you're alluding to, what that neglects is the idea is that when we bring care force to the US, we're taking care force from other parts of the world. And we have to rectify that imbalance. And I think, as that care force becomes increasingly globalized, we need to think about it as a global aging and aging care as a global phenomenon. And how does that care become reciprocal? How do we make sure it's ethical? How do we make sure the care goes both ways? How do we make sure folks who come here have the ability to care for their loved ones at home? I think all of those things are incredibly important. So I'm, as a, as a U.S. nursing home advocate, I'm really hoping that we see immigration reform that supports our nursing home. I also hope that immigration reform is forward-looking enough and holistic enough and humanistic enough to think about the global ramifications and how we pay that care back and think about those connections. So I completely agree with what you're saying. And, I think globalizing, it's what I think makes this group IFA important, right? Is like globalizing these conversations is so important. So I'm yeah, right there with you.
Thank you so much. And thank you, Nadine, for bringing up important points. It's really is a global issue, and it's a lot of what a lot of these countries need to consider, either, immigrating or, taking in these care workers. We really need to establish kind of guidelines and like a framework and an understanding, I think, most importantly, of kind of what the situation is and really rectify that. So thank you so much for bringing up those important points, and thank you, Isaac, for answering that. There are so many wonderful comments and questions here, so I'm just gonna go to, let's see over here. There's a comment here from a question here from Francis. She mentioned you mentioned that the largest growth in nursing home populations is younger, so under the age of 65. Can you say more about this group? Is this due more to chronic physical problems, early onset dementia, any other conditions from your perspective in the US?
Yeah, this is something I'm really interested in, and if you go and look at the NASM report, which you may after this call, which would be very exciting, you will find a little bit on this topic, though not a lot. And the reason there's not a lot is because it's pretty under-researched. So our sort of sense of the issue overall in the U.S. is the picture isn't all that clear yet. I think anecdotally and from what data we do have, one of the things we know is that the failures of our behavioral healthcare system and our mental health care system, and also our substance use care system in the US are having trickle-down effects on our nursing homes. So in a lot of cases, nursing homes become the only place in theory, equipped to care for younger adults with behavioral health, mental health, and substance abuse needs. However, that in theory is in theory because nursing homes are actually not really equipped to care for these folks, right? Like if you have a young adult with substance use disorder living in a rural area that's suddenly living in a wing of a nursing home designed for folks with dementia, you can see what the problems there would start to be pretty quickly. And so the big challenge for us now, right, is like, how do we try to provide appropriate care for these folks when they are in nursing homes? Should they really be in nursing homes at all? And, what do we do about that? So there's a lot of research that still needs to be done on this. And, nursing homes are adapting on the fly, really, right? And having, I think, a lot of trouble doing it. So it's a huge problem, and we need more information on what the nature of that is. But a lot of it is due to failures in the behavioral healthcare system.
Good to know. Thank you so much. And thank you, Francis, for posing that question. So now that we are quickly coming close to the end of today's Global Cafe, before we wrap up, I would love to hear your key takeaways from today's discussion. So I'll give you a little time to just gather some of your thoughts as I'll introduce our next week's topic and speaker right now. So please join our discussion next week for our third and final session of our Global Cafe Pain Management series with Dr. Whitney Scott on the topic of promoting equitable access to holistic and person-centered pain care. So please join us to listen to that great discussion next week. It'll also be our final Global Cafe for 2024. So we look forward to seeing all of you there. So we're back to you now, Isaac. So in a few sentences, what are some of your key takeaways from our conversation today?
Thanks, and thanks everyone for having me today. It's been really nice to talk to you all, and I will say that Atali and Luana, you please make my email available. I'm happy to follow up with anyone. I think from the wonderful conversation we've had, I really have been drawn to those bigger issues, right? We talked a little bit about equity in nursing homes and socioeconomic equity in particular. We talked about sort of changing political landscapes in the US. And of course, we talked about sort of the global implications of care force changes, and how we create a global system that's really providing high quality care for everybody. And I think, as a coalition, we, as I've talked about, we operate at the level of quality improvement initiatives, which are really on the ground. I love that work because it's all about making the lives of individuals better every day. We talk a lot about intermediate issues in terms of some of the policies and the weed policies of financing physical plant changes. And we didn't get to talk too much about ownership, accountability in nursing homes and some of those other intermediate changes. But, as our coalition continues to grow and get stronger, I think we want to elevate to some of these bigger conversations as well, and really, bring together support for those bigger picture conversations. So thank you to the folks who sort of brought, Catherine and Nadine, and there was at least one other person on this call who really, raised some of those bigger issues, and, excited to continue to participate in that conversation to really put our foot in the ground on how we can improve some of those bigger picture questions, and hope you all will, join us and support us in that charge. So thank you so much for having me. Thank you so much for the inspiration that you bring to the Moving Forward Coalition and to nursing home quality improvement.
Thank you so much, Isaac. And so before we sign off, I would like to thank everyone again for another great week of our Global Cafe sessions, with special thanks to Mr. Isaac Longobardi for joining us today. And great thanks to the incredible people here working at the IFA who have supported this and every Global Cafe, in particular Ms. Luana Caldnago. And also, as an ending note, IFA is nearing 5 years of our Global Cafe series. We have launched a survey to get some feedback on how to make this experience more impactful and meaningful to you. So we'd absolutely appreciate taking your time to complete the survey. Luana's posted in the chat. So thank you all. Thank you again, Isaac, for this wonderful conversation. And we hope to see you all next Friday. Take care, everyone. Have a great weekend.
Bye-bye.